Welcome to Pediatric Case Review. Today we will explore mitral stenosis in pediatric patients, a condition that requires early recognition and appropriate management. This lecture will cover the etiology, epidemiology, pathophysiology, clinical presentation, diagnosis, and management of mitral stenosis in children. Understanding this condition is crucial for general pediatricians as it can have significant implications if not properly identified and managed. A 7-year-old girl presents with exercise intolerance and recurrent respiratory infections. She has a history of rheumatic fever 2 years ago. What is the most likely etiology of mitral stenosis in this patient? Option A, congenital mitral stenosis. Option B, rheumatic heart disease. Option C, mitral valve prolapse. Option D, cardiomyopathy. Consider the patient's history of rheumatic fever in a typical presentation. The correct answer is B, rheumatic heart disease. Rheumatic heart disease remains the leading cause of mitral stenosis globally, particularly in developing countries. While congenital forms of mitral stenosis exist and are important in pediatric populations, they are less common than acquired forms. The history of rheumatic fever in this 7-year-old patient is a key indicator that the mitral stenosis is likely secondary to rheumatic heart disease. This highlights the importance of preventing and appropriately treating rheumatic fever to avoid long-term cardiac complications. Which statement about the epidemiology of pediatric mitral stenosis is correct? Option A, it affects boys more commonly than girls. Option B, it is equally prevalent in developed and developing countries. Option C, it is more common in populations with high rates of streptococcal infections. Option D, most cases present in the first year of life. Consider the global distribution and risk factors for rheumatic heart disease. The correct answer is C. It is more common in populations with high rates of streptococcal infections. There are significant geographic and socioeconomic disparities in the prevalence of rheumatic heart disease, with higher rates in developing countries and areas with limited access to healthcare. Contrary to option A, there is actually a female predominance in rheumatic mitral stenosis. Option B is incorrect as the prevalence is much higher in developing countries. Option D is also incorrect as most cases of rheumatic mitral stenosis present later in childhood, not in the first year of life. This highlights the importance of preventive strategies in high-risk populations. What is the primary hemodynamic consequence of severe mitral stenosis in children? Option A, decreased left ventricular preload. Option B, left atrial pressure overload and dilation. Option C, right ventricular volume overload. Option D, decreased cardiac output only during exercise. Consider the flow of blood through the heart and the effects of a narrowed mitral valve. The correct answer is B, left atrial pressure overload and dilation. In mitral stenosis, the narrowed mitral valve restricts blood flow from the left atrium to the left ventricle during diastole. This obstruction leads to increased pressure in the left atrium, causing it to dilate over time. While option A is partially correct, decreased left ventricular preload is a consequence rather than the primary hemodynamic consequence. Option C, right ventricular volume overload, occurs later as a result of pulmonary hypertension. Option D is incorrect as decreased cardiac output occurs both at rest and during exercise in severe mitral stenosis. The left atrial pressure overload is the primary hemodynamic disturbance that initiates the cascade of changes seen in this condition. A 10-year-old presents with progressive dyspnea on exertion, fatigue, and orthopnea. Which additional symptom would most strongly suggest mitral stenosis? Option A, chest pain radiating to the left arm. Option B, hemoptysis. Option C, syncope with exercise. Option D, palpitations only at rest. Consider the pathophysiological mechanisms of mitral stenosis and how they might manifest as specific symptoms. The correct answer is B, hemoptysis. Hemoptysis is a classic symptom of mitral stenosis that results from pulmonary venous hypertension. When left atrial pressure rises significantly due to the stenotic mitral valve, it leads to increased pulmonary venous pressure, which can cause rupture of small bronchial veins, resulting in hemoptysis. While chest pain can occur in mitral stenosis, it's not typically radiation to the left arm, which is more characteristic of coronary ischemia. Syncope with exercise is more commonly associated with outflow obstructions like aortic stenosis. Palpitations can occur in mitral stenosis due to atrial arrhythmias, but they are not specific to this condition and can occur at rest or with activity. The progression of dyspnea from exertion to orthopnea, and eventually to paroxysmal nocturnal dyspnea, is characteristic of worsening mitral stenosis. An 8-year-old with history of rheumatic fever presents with new-onset dyspnea. When do symptoms of rheumatic mitral stenosis typically appear after the initial rheumatic fever episode? Option A, immediately after the acute episode. Option B, 1 to 3 months after. Option C, 5 to 10 years after. Option D, only in adulthood. Consider the natural history of rheumatic heart disease and the progression of valve damage. The correct answer is C, 5 to 10 years after. There is typically a latent period between the acute rheumatic fever episode and the development of symptomatic mitral stenosis. This latent period usually ranges from 5 to 10 years, during which progressive valve damage occurs. Option A is incorrect because symptoms do not appear immediately after the acute episode. Option B, 1 to 3 months, is too short for significant valve damage to occur. Option D is also incorrect because while rheumatic mitral stenosis can certainly persist into adulthood, symptoms often begin in late childhood or adolescence, not exclusively in adulthood. This latent period emphasizes the importance of long-term follow-up after rheumatic fever, even if the child appears well initially, to detect and manage cardiac complications before they become severe. During examination of a child with suspected mitral stenosis, which auscultatory finding is most characteristic? Option A, mid-systolic click. Option B, diastolic rumbling murmur. Option C, high-pitched holosystolic murmur. Option D, continuous machinery murmur. Consider the timing and quality of murmurs associated with different valvular heart conditions. The correct answer is B, diastolic rumbling murmur. The diastolic rumbling murmur is the classic auscultatory finding in mitral stenosis. This low-pitched murmur is best heard at the cardiac apex using the bell of the stethoscope, as it is caused by turbulent blood flow across the stenotic mitral valve during diastole. Option A, mid-systolic click, is characteristic of mitral valve prolapse, not mitral stenosis. Option C, high-pitched holosystolic murmur, is more typical of mitral regurgitation or ventricular septal defect. Option D, continuous machinery murmur, is pathognomonic of patent ductus arteriosus. In mitral stenosis, an opening snap often precedes the diastolic murmur, and the intensity and duration of the murmur correlate with the severity of the stenosis, making it a crucial finding in the physical examination. A 9-year-old with mitral stenosis is being examined. Which physical finding would not be expected in this patient? Option A, right ventricular heave. Option B, accentuated first heart sound. Option C, wide pulse pressure. Option D, opening snap after S2. Consider the hemodynamic changes that occur in mitral stenosis and their physical manifestations. The correct answer is C, wide pulse pressure. In mitral stenosis, a narrow pulse pressure is actually expected, not a wide one. This occurs because the reduced cardiac output and fixed stroke volume lead to a smaller difference between systolic and diastolic blood pressure. Option A, right ventricular heave, is expected in mitral stenosis as it indicates pulmonary hypertension, which develops secondary to chronic left atrial pressure elevation. Option B, accentuated first heart sound, is characteristic of mitral stenosis due to the forceful closure of a stiffer but still mobile mitral valve. Option D, opening snap after S2, is also a classic finding in mitral stenosis, caused by the sudden tensing of the stenotic mitral valve leaflets in early diastole. The timing of the opening snap correlates with the severity of the stenosis, with earlier snaps indicating more severe disease. A 6-year-old presents with exertional dyspnea and a diastolic murmur. What is the most appropriate first diagnostic test to confirm mitral stenosis? Option A, electrocardiogram. Option B, chest X-ray. Option C, transthoracic echocardiography. Option D, cardiac MRI. Consider the diagnostic approach for valvular heart disease in children and the most accurate, non-invasive method for evaluation. The correct answer is C, transthoracic echocardiography. Transthoracic echocardiography is the gold standard diagnostic test for mitral stenosis and is the most appropriate first diagnostic test in this case. It provides detailed visualization of the mitral valve morphology, allows assessment of valve function, and enables accurate calculation of the mitral valve area, which is crucial for determining the severity of stenosis. While electrocardiogram and chest X-ray may show supportive findings, such as left atrial enlargement or P mitral on ECG, or left atrial enlargement and signs of pulmonary congestion on chest X-ray, they are not diagnostic. Cardiac MRI, while providing excellent anatomical detail, is more expensive, less readily available, and typically reserved for cases where echocardiography is inconclusive or when additional information is needed. Which echocardiographic finding is consistent with severe mitral stenosis in a child? Option A, mitral valve area greater than 1.5 square centimeters. Option B, mean pressure gradient less than 5 millimeters of mercury. Option C, doming of the anterior leaflet with restricted motion. Option D, normal left atrial size. Consider the echocardiographic parameters used to diagnose and grade the severity of mitral stenosis. The correct answer is C, doming of the anterior leaflet with restricted motion. This finding, often described as a hockey stick appearance of the anterior mitral leaflet in diastole, is a classic echocardiographic feature of mitral stenosis. It occurs due to commissural fusion and thickening of the valve leaflets, which restrict their normal motion. Option A is incorrect because a mitral valve area greater than 1.5 square centimeters actually indicates mild or no stenosis, not severe stenosis. Option B is also incorrect because a mean pressure gradient less than 5 millimeters of mercury suggests mild stenosis, whereas severe stenosis typically has gradients greater than 10 millimeters of mercury. Option D is incorrect because severe mitral stenosis invariably causes left atrial enlargement due to chronic pressure overload. A normal left atrial size would essentially rule out significant mitral stenosis. A 12-year-old with severe mitral stenosis is being evaluated for intervention. Which test would best help determine the suitability for balloon valvuloplasty? Option A, exercise stress test. Option B, transesophageal echocardiography. Option C, cardiac catheterization. Option D, cardiac CT scan. Consider the detailed assessment needed to evaluate valve morphology before planning a balloon valvuloplasty procedure. The correct answer is B, transesophageal echocardiography. Transesophageal echocardiography provides superior visualization of the mitral valve morphology and subvalvular apparatus compared to transthoracic echocardiography. This detailed assessment is crucial for determining the suitability of balloon valvuloplasty, as the procedure works best in pliable valves with commissural fusion and minimal calcification or subvalvular disease. While cardiac catheterization can provide hemodynamic data and was historically used for this purpose, transesophageal echocardiography has largely replaced it for pre-intervention planning in most centers. Exercise stress test may help assess functional capacity, but does not provide the detailed anatomic information needed. Cardiac CT scan can show calcification, but does not provide real-time dynamic assessment of valve function. A 10-year-old with mild mitral stenosis has sinus tachycardia. Which medication would be most appropriate? Option A, digoxin. Option B, beta blocker. Option C, ACE inhibitor. Option D, diuretic. Consider the hemodynamic goals of medical therapy in mitral stenosis and how different medications might affect the pathophysiology. The correct answer is B, beta blocker. Beta blockers are the most appropriate medication for this patient with mild mitral stenosis and sinus tachycardia. By slowing the heart rate, beta blockers prolong diastolic filling time, which is particularly beneficial in mitral stenosis where blood flow across the stenotic valve occurs during diastole. This improves hemodynamics and can help alleviate symptoms. Digoxin, option A, is less ideal as it increases myocardial contractility, which is not typically needed in mitral stenosis and can potentially increase myocardial oxygen demand. ACE inhibitors, option C, are generally not recommended in isolated mitral stenosis as they can cause significant hypotension due to reduced cardiac output. Diuretics, option D, may be used in moderate to severe mitral stenosis with pulmonary congestion, but are not first line for mild disease without signs of volume overload. A 9-year-old with severe mitral stenosis has calcified leaflets and severe subvalvular fusion. Which intervention would be most appropriate? Option A, medical management only. Option B, percutaneous balloon mitral valvuloplasty. Option C, surgical commissurotomy. Option D, mitral valve replacement. Consider the valve characteristics that determine the suitability of different interventions for mitral stenosis. The correct answer is D, mitral valve replacement. In this 9-year-old with severe mitral stenosis characterized by calcified leaflets and severe subvalvular fusion, mitral valve replacement would be the most appropriate intervention. The presence of significant calcification makes the valve unsuitable for balloon valvuloplasty, option B, which works best on pliable, non-calcified valves with primarily commissural fusion. Surgical commissurotomy, option C, would also be unlikely to succeed given the severe subvalvular fusion and calcification. Medical management alone, option A, would be inadequate for severe symptomatic mitral stenosis. While valve replacement is typically avoided in children when possible due to the need for future reoperations as the child grows and the requirement for long-term anticoagulation, in this case with unfavorable valve morphology, replacement becomes necessary. A 5-year-old requires mitral valve replacement for severe mitral stenosis. Which factor is most important when considering mitral valve replacement? Option A, cosmetic scar concerns. Option B, need for growth accommodation and anticoagulation. Option C, cost of the procedure. Option D, duration of hospital stay. Consider the unique challenges of valve replacement in young children compared to adults. The correct answer is B, need for growth accommodation and anticoagulation. When considering mitral valve replacement in a 5-year-old child, the need for growth accommodation and anticoagulation is the most important factor. Prosthetic valves do not grow with the child, necessitating future reoperations as the child outgrows the implanted valve. Additionally, mechanical valves require lifelong anticoagulation to prevent thrombosis, which presents significant challenges in young children, including compliance issues, monitoring difficulties, and increased risk of bleeding. While cosmetic concerns, option A, cost, option C, and hospital stay, option D, are all considerations, they are secondary to these fundamental issues of growth and anticoagulation. This is why valve repair is always preferred when possible in pediatric patients, as it preserves the native valve tissue that can grow with the child and eliminates the need for long-term anticoagulation. When replacement is necessary, these factors must be carefully weighed in the decision-making process. A 13-year-old with long-standing mitral stenosis presents with acute onset of right-sided hemiparesis. What is the most likely cause? Option A, infective endocarditis. Option B, left atrial thrombus with embolism. Option C, brain abscess. Option D, hypertensive emergency. Consider the complications associated with chronic mitral stenosis and how they might manifest as neurological symptoms. The correct answer is B, left atrial thrombus with embolism. In this 13-year-old with long-standing mitral stenosis presenting with acute right-sided hemiparesis, the most likely cause is embolization of a left atrial thrombus to the brain. Chronic mitral stenosis leads to left atrial enlargement and blood stasis, which creates a favorable environment for thrombus formation. When these thrombi dislodge, they can embolize systemically, with the brain being a common site, resulting in stroke symptoms such as hemiparesis. While infective endocarditis, option A, can also cause embolic phenomena, it typically presents with additional signs of infection such as fever. Brain abscess, option C, usually develops more subacutely and is often associated with predisposing factors like congenital heart disease with right-to-left shunting. What is the recommended frequency of echocardiographic follow-up for a stable child with moderate mitral stenosis? Option A, every month. Option B, every 3 to 6 months. Option C, every 1 to 2 years. Option D, only when symptoms worsen. Consider the natural progression of mitral stenosis and the appropriate monitoring intervals based on disease severity. The correct answer is C, every 1 to 2 years. For a stable child with moderate mitral stenosis, echocardiographic follow-up every 1 to 2 years is recommended. This interval balances the need for regular monitoring with the practical aspects of healthcare delivery. Follow-up frequency is tailored to disease severity. Mild mitral stenosis typically requires follow-up every 3 to 5 years, moderate disease every 1 to 2 years, and severe disease every 6 to 12 months. Option A, monthly follow-up, is excessive and not indicated for stable moderate mitral stenosis. Option B, every 3 to 6 months, would be more appropriate for severe disease or unstable moderate disease. Option D, only when symptoms worsen, is inadequate because mitral stenosis can progress silently before symptoms develop, and early detection of progression allows for timely intervention. The progressive nature of rheumatic mitral stenosis necessitates regular monitoring to detect changes that might indicate the need for intervention, as early timing of intervention improves long-term outcomes. Thank you for joining us for this comprehensive lecture on mitral stenosis in pediatrics. We have covered the etiology, pathophysiology, clinical presentation, diagnostic approach, and management of this important condition. Remember that early recognition and appropriate management are crucial for optimal outcomes in children with mitral stenosis. Please follow Pediatric Case Review for more informative presentations on pediatric conditions. And if you have any questions or comments, please leave them below. We appreciate your engagement and look forward to seeing you in our next presentation.